Buenas noches a todos. Tengo el gran honor de presentar a los panelistas que van a participar hoy en la sesión mensual que realizamos por parte de la Sociedad de Cirujanos de Colon, Recto y Ano. Eh, el doctor, el profesor Peter Sarov, él es el presidente de la Sociedad Rusa de Coloproctología. Tenemos también a la doctora Ina Tulina. Ella es cirujana coloproctóloga de la Universidad Federal de Moscú. Eh, y tenemos como invitado también al doctor Vladimir Balabán. Él no se encuentra ahorita presente, pero se unirá a la parte de preguntas y respuestas. Y como moderadores tenemos al doctor Miguel Ángel Rosado, miembro de la Sociedad, jefe de enseñanza del Hospital Cristus Muguerza, coloproctólogo egresado del Hospital Iste López Mateos, y al profesor Ricardo Escalante, actual vicepresidente de ISURGS, cirujano coloproctólogo, coronel retirado. Y bueno, sin más preámbulo, vamos a dar inicio a la plática. I have the privilege to introduce the president of the Russian Society of Colorectal Surgery, Professor Peter Sarov. He's going to talk us about advanced rectal cancer and the management of the pelvic bone reconstruction after cancer resection. Please, Professor, the floor is yours.
Thank you very much. Good morning, everybody. Here in Europe, part of the world, it is early morning, but I know that it is evening in your part of the world. Anyway, this possibility, technical possibility, can connect us and to communicate for every question in colorectal surgery. We are glad to be with Mexican society, and so I'm very glad to see my old friend Ricardo Escalante from Venezuela. We know each other. I don't know exactly how many years, and new friends from Mexico. Mexican Society of Colorectal Surgery. It is a great privilege to participate in this meeting, and me with my colleagues, we will talk today about advanced rectal cancer, rectal cancer, advanced cases of rectal cancer, and try to highlight of only some question of this complicated theme. Let me start with my presentation. Is it possible to see?
Yes, we can see your screen.
Yeah. Okay. Okay, I will talk about pelvic bone resection and reconstruction for locally advanced rectal cancer. If you look at the incidence of extensive surgery for advanced rectal cancer beyond the TME, it is about 5 to 15% in when we look at the literature. We know that we need to do in these complicated cases, even if you use radiotherapy, chemoradiotherapy, we need to reach and block R0 resection, which give us survival around 40 to 60% in modern time. But we also know that true tumor invasion will be find out only in 50% in such complicated surgery. If we know that tumor can advance to the different ways in the pelvis. In case of anterior compartment involvement, in men, the organs will presented in my slide, and very rare we can see the involvement of pubic bone in advanced cases. The same it's for women. More often we can see involvement of sacrum bone or presacral fascia, also anterior longitudinal sacral ligament if tumor grows to the posterior direction. This kind of involvement looking like this, it is a case after radiation therapy when the tumor was distracted during the treatment and the sacrum bone around the S4 and even S3 involved this big cavity with the cancer wall during this. Usually it needs us to be very interested of obturator area in such complicated cases. But it is not a theme of my talk. It will be a highlight of in Tulina. We also can see that very often in these and such complicated cases, we need to resect some iliac vessels during such kind of resection. And it means that we should be very familiar with vascular surgery. That's why we usually denied, we doctors, not only our patients, we usually denied such complicated surgery. And only some of us decided to operate these complicated patients. What is our fears and horrors during this extension of resection? We think that it may be bleeding from the presacral vessels and also from spongy bone. Also, we afraid iliac vessels bleeding, difficulties with reconstruction, and also we should be familiar with lateral lymph node dissection. What about presacral bleeding? There are many publications about the dangers of this bleeding during colorectal and rectal cancer surgery, and also publication about the method of stopping of this bleeding. You can see even explanation about this kind of bleeding. We also, but in our opinion, the main reason when we can have lethal exitus during this bleeding is the damage of iliac veins, which can located unusual. Here you can see the simple location and usual location of common iliac vein near the sacrum promontory. But from time to time, we can see some big iliac vessels like this, located near the sacrum promontory. In this particular case, the bleeding may be very massive, and we should prepare to do something with these. Usually, we use during the surgery separation of all iliac vessels, and we call it to have a control about these big vessels. For example, in this case, you can see doubled vena cava. Sometimes the vascularity of pelvic structures is very, very unusual, like in this case. I will not talk about lateral lymph node dissection, and also we need to do and to be familiar with sacrum resection. When we start our activity in this area, we usually invited orthopedic surgeon and specialized in vertebral surgery. But we, unfortunately, we understand that their maneuvers during the surgery is not so quite good for rectal cancer surgery, because it needs to how to say they are not so familiar with R0 or resection in their cases. What should we do during diagnostic of the advanced cancer cases? We usually use such maneuver. We use MRI with special latex tube located on the sacrum. You can see here the some marks on the skin of the sacrum, which we marked also using marker on the sacrum region. And you can see that during surgery, we can understand where we should do our line of resection during the posterior part of our procedure. Sometimes we can see not real involvement of the sacrum bone during the MRI technique. That's why we usually use extrafascial resection, including in the plan of dissection presacral fascia, and in this case fascia of Valdeir. And it gives us the possibility to achieve R0 resection. But usually we also need the sacrum resection in the case of involvement of sacrum bone. Here you can see our technique, very quick video. It is open technique in this part of our procedure. From the abdominal side, the last several years, we try to use laparoscopic or robotic technique, but it's also possible to use open technique. We clear sacrum bone from the perineal muscles and gluteus muscles, clear the bone. And after that, at the beginning, we used special knives for the bone resection, and you can see it possible to do very easily way without any problem during the surgery. And you can also you can also see that the level of the bleeding during this procedure is not huge. Here we can see the other technique using the jiggly jiggly instrument. You can see that it looks more simple, and even if you see the some bleeding, you can see also that it is not so big bleeding. After a resection of the pelvis, we invert our specimen to the perineum part of our procedure, and you can see that it gives us a very nice control of any kind of bleeding during this procedure. Uh, you can see the operating field after removing of the specimen. Here I would like to demonstrate if it will be seen during my presentation. You can see some bleeding during the procedure, but when we move specimen, you can see that only two bleeding vessels you can see, and it is presacral vessels which were stopped very easily using electrocautery. Here you can see the post-operative specimen and wound after procedure, and you can see this is a big and huge operative field after such kind of extensive procedure. And the other problem is reconstruction of the pelvic floor. We very often used in this case gluteus muscles plastic. You can see here some maneuver during this kind of plastic. We mobilized gluteus maximus muscle from the skin and fat tissue, moved it centrally, and after that the wound will look like this after the end of this procedure. We also published some data about the possibility to use laparoscopic technique in such kind of extensive procedure for big presacral tumors. You can see the size of these tumors was huge, but anyway, we used laparoscopic part of procedure for mobilization of the upper part of this tumor. We have 32 cases in this series. You can see that the majority of patients had recurrent disease, and half of them had radiotherapy before the operation. You can see the type of surgery and type of resection, and you see that the majority of patients has not so high level of resection of the sacrum. We compare the results of 23 of these patients with usual extirpation of the rectum, and find out that the difference was only in the blood loss and operative time. The big problem of this high level of resection is urinary bladder disorders, especially when we use a high level of resection. And there was not so many so-called major post-operative complications. Only 9%, 3 cases need to be reoperated in the post-operative surgery. You can see also that we, from time to time, we need to resect a pubic bone resection. This is a demonstration which was published in 2020. We need to resect a very huge part of the pubic bone. From the left side, you can see the defect more than around the 10 centimeters between the pubic bone from the left side. And we used first in the world, we used a special prosthesis from titanium implant looking as a sponge. And it was successfully used for the pelvic bone continuity. Pubic bone continuity, and the patients after this reconstruction can move herself after 1 month of this complicated surgery. What can I say in the end of my demonstration? Don't try to divide adhesions, and block resection is whenever possible, even if pelvic bone is involved in these advanced cases. You have know the anatomy very well, presacral, obturative space, iliac vessels, and you should communicate with the other surgeons for the beginning as a minimum, and try to develop your skills. Thank you very much for your attention.
Thank you so much, Prof, for your wonderful presentation. We are going to move on for our next speaker. I want to introduce Dr. Ina Tulina. She is an associate professor of the Department of Colorectal and Endoscopic Surgery from Chenov First Moscow State Medical University. She has a fellowship in Severan Hospital in South Korea. She's going to talk us about indications for lateral lymph node dissection. Please, Dr. Ina.
Dear colleagues, it is a great pleasure for me to participate in this joint seminar of the Mexican Society of Coloproctology and Russian Society of Colorectal Surgery. So I would like to share with you our experience with the lateral pelvic lymph node dissection. This is the topic that we actively develop for more than 30 years, and it started with Professor Tsarkov that learned this technique in Japan, and since then he has been implementing it in the practice of the clinic of colorectal surgery where we all work now, and also he has been propagating this around the world. Now we have a certain experience in this topic that I will show you now. So we have presented this experience last year at the American Society of Colorectal Surgeons, and this presentation won one of the awards there. So what to start with? Lateral pelvic lymph node dissection is a difficult topic for colorectal surgeons, especially in the Western world, because the perception of this technique is that maybe it is not really needed, because metastases to lymph nodes are relatively rare. If a patient has metastasis to lateral lymph nodes, they are equal to distant metastasis and nothing has to be done. If there are metastases to lateral lymph nodes, it is very difficult to remove them, and only in Asian patients it is possible. So we can see in the literature the publications mostly from Japan, South Korea, China now, but relatively no publications from the Western countries. And lateral pelvic lymph node dissection is associated with extensive morbidity. It's a difficult procedure, and probably chemoradiotherapy can replace this surgery and can do the same job, but safely, and no need to do this very difficult operation. So what are the real indications to lateral pelvic lymph node dissection in this setting? So just a little reminder about the history. This procedure was developed in Japan since 1940s. There has been very huge scientific work about the anatomy, the distribution of lateral pelvic lymph nodes, and the first reports were published since 1970s or 80s, and at that time the major indication for lateral pelvic lymph node dissection was locally advanced low rectal cancer, T3, T4 rectal cancer that is below the peritoneal reflection. At that time, different groups from Japan published the incidence of metastasis in lateral pelvic lymph nodes for that type of indication from 7 to 42%. When we have got MRI to diagnosis of rectal cancer, we acquired a tool to select the patients for lateral pelvic lymph node dissection. And nowadays, there are different indications based on MRI. So if lateral pelvic lymph nodes are greater than 5 millimeters or 8 millimeters, in some centers in Japan, this is an indication for lateral pelvic lymph node dissection, a selective lateral pelvic lymph node dissection. And in this situation, the incidence of metastatic lymph nodes in this area has reached up to 65%, but not 100% still. So we still are seeking some precise indications for lateral pelvic lymph node dissections. Right now, we have only some clinical indications like tumor characteristics, and we have MRI that we can measure mostly enlargement of lateral pelvic lymph nodes. If we base our indications only on the size of lateral pelvic lymph nodes, we can get two situations. One is that MRI size gives us false positive results. So the lateral pelvic lymph node is enlarged, but it doesn't contain any metastatic disease. In that case, we can do lateral pelvic lymph node dissection unnecessarily, and probably the patient can get some morbidity associated with this operation. If on MRI, the lateral pelvic lymph nodes are not enlarged, they are very small, but still they can have metastatic disease. In that situation, we don't perform lateral pelvic lymph node dissection, and the patient can get local recurrence. This has been demonstrated in the work that was previously done by Professor Tsarkov, that in some lymph nodes, lateral pelvic lymph nodes that are less than 5 millimeters in diameter, still can be found metastatic cells. One of the group from Japan has developed a special nomogram. They have accumulated different clinical parameters, that is the diameter of lateral pelvic lymph nodes on MRI, tumor location, so the tumors that are close to anal canal have the greater possibility of lateral pelvic lymph node metastasis. The status of extramural venous invasion and the short access of mesorectal lymph nodes, because the patients who have lymph node metastasis in the mesorectum, they have a greater possibility of lateral pelvic lymph node metastasis. And this nomogram showed very high negative predictive value. So if all the parameters are negative, probably the patient doesn't have any lateral pelvic lymph node metastasis, but very moderate positive predictive value. So still, we can't effectively predict the patients who have lateral pelvic lymph node metastasis. So that's why we have conducted our trial, because there are unsolved questions. We can't rely on the size of lateral pelvic lymph nodes. We can't rely just on the clinical features. And there is no firm confirmation that in Western population, the same rules as in the Eastern population from Japan, Korea, China. So how can we extrapolate the results from that countries to our patients? So the aims of our study was first to describe the lateral pelvic lymph node involvement in so-called Western patients that come to our clinic in Russia, and to create a special tool that can combine clinical features and radiological features to predict lateral pelvic lymph node involvement. So the first part of our trial was to retrospectively describe the patients who underwent lateral pelvic lymph node dissection. They all had rectal adenocarcinoma, they all had pelvic MRI, and they had lateral pelvic lymph node dissection, so we can say what were their clinical and radiological features. And we developed a special score. We called this lateral pelvic lymph node score. And then in the second part of our trial, we applied this score to prospective cohort of patients, and we tried to find out if this score works to predict lateral pelvic lymph node metastasis. So the first cohort of patients that was retrospectively evaluated, this was 120 patients. They were operated in a 10-year period. And among these 100 patients who had lateral pelvic lymph node dissection, this operation was mostly performed because on MRI, this patient had enlarged lateral pelvic lymph nodes. This was 73%. But in some patients, we performed this operation prophylactically. The patients didn't have enlarged lateral pelvic lymph node on MRI, but still we did lateral pelvic lymph node dissection to them. And what about pathologically confirmed metastasis in lateral pelvic lymph nodes? Among these 120 patients, 35 patients had pathologically confirmed metastasis. This is about 30%. And among these confirmed patients, only 1/3, 34% had enlarged lateral pelvic lymph nodes. So we see that not only the size of lateral pelvic lymph node can predict the metastasis in these lymph nodes. About 20% of patients had either small or no visible lateral pelvic lymph nodes on preoperative MRI. So we see that sensitivity of MRI can be rather high, about 84%, but specificity, so the ability to predict metastasis, either in mesorectum or in lateral pelvic area, is very low. And this is the results from our clinic, where the MRI specialists are very high level. We educate them for all these 10 years, so they have special courses, so they teach other MRI specialists, but still their ability to predict lateral pelvic lymph node metastasis is very low. So what are the clinical features we studied in these patients? We found out that if a patient had mesorectal lymph node positive, they also had lateral pelvic lymph nodes. This was 86%. If the tumor was T4, also the possibility of lateral pelvic lymph node metastasis was also higher. If the tumor was mucinous or colloid, also it gave us the higher possibility of lateral pelvic lymph node metastasis, and patients with MVI status also had a higher possibility of lateral pelvic lymph node metastasis. So we joined all these parameters in one score. We made a stepwise, very complex statistical analysis. We joined all these factors together. We made a special calculation, and the product of this calculation we called the lateral pelvic lymph node score. So we put in this score the distance from the anal verge, the EMVI status, the size of lateral pelvic lymph nodes on MRI, the stage on MRI, and tumor differentiation before surgery. So this is just adenocarcinoma, moderately differentiated, or mucinous, or signet cell, and gave some scores to each of these parameters, put them all together, and calculated the result of this equation. And we found out the cutoff value of this equation. So a cutoff value of 1.23 gave us the possibility to predict the high possibility or low possibility of lateral pelvic lymph node metastasis. So just two examples how this score works. For example, we have a patient number 1 with a tumor at 4 centimeters from the anal verge. This is score 1. That has EMVI positive status, also 1. That has no visible lateral pelvic lymph nodes on MRI, but has a locally advanced tumor T4 and moderately differentiated tumor. So when we put this all together in the equation, we see that the score is low, is high, and we see that lateral pelvic lymph node dissection is indicated even though we have no visible lateral pelvic lymph nodes on MRI. The other patients, we see that it is a high tumor with no EMVI, but with enlarged lateral pelvic lymph nodes. But still, this patient doesn't need lateral pelvic lymph node dissection. So we applied this score to prospective cohort of patients, 66 patients, and we found out we did lateral pelvic lymph node dissection for the patients who had greater score, greater than 1.23, but also for some patients with a low score, we still did lateral pelvic lymph node dissection because they had big lateral pelvic lymph nodes on MRI. We can't omit this indication that is widespread. So based on this, we had two scores to compare. One is our score, also only based on this equation, and the score and the indication based on MRI greater than 7 millimeters. So what we found out that even the size of the lateral pelvic lymph nodes on MRI can't effectively predict lateral pelvic lymph node metastasis, but our clinical radiological score had the greatest sensitivity, greatest specificity among all these scores, and that is why it can be used in everyday practice to select patients for lateral pelvic lymph node dissection. Of course, we have some limitations because it is based on a single center experience. The score was developed on a retrospective series, but still we need some time and we need clinics to imply the score and to find out how it works in a greater cohort of Western patients. So this is the first really big experience of lateral pelvic lymph node dissection in Western patients. we showed that MRI is not the only reliable predictor. It is not really a reliable predictor of lateral pelvic lymph node metastasis, and we need to combine different parameters of the tumor, the height of the tumor, its histological grade, and the size of lateral pelvic lymph nodes to find out the patients who really need lateral pelvic lymph node dissection, and lateral pelvic lymph node score is a good tool to do that. And from the side of Russian Society of Colorectal Surgeons, we cordially invite Mexican surgeons to attend Russian School of Colorectal Surgery in September. It will take place on 22nd September. We discuss all different kinds of questions, starting from colorectal cancer to different proctological problems, and many renowned experts from all over the world join us, and from Mexico as well. So we will be very glad to see you in Moscow in September. Thank you for your attention.
Thank you so much, Dr. Ina, for your wonderful presentation. We are moving to the last speaker. Here is Dr. Vladimir Balaban. He is a colorectal surgeon. He's member of the Russian Colorectal Society of Coloproctology. He is colorectal surgeon of the Chenov First University, Moscow State Medical University. He has the kindness to send me his lecture. I will play it for him, and he will join us for the question and answer section. Wait a second, I will share the screen. Can you see the screen? Doctor Miguel Ángel, ¿ven la pantalla?
Sí.
Ok, voy a correrla.
Yes.
Dear ladies and gentlemen, I understand that this slide is not worst, so maybe from my once again, because right now I sit in reception on one of the hotels, so I try to start. Could you give me rules? I can start my.
Okay, there's no problem. We can stop them and you can share your presentation, Doctor, without problem. Thank you very much.
Okay.
So how can I start my presentation?
You have to share your screen, please.
But I don't have possibility to do it. You can't demonstrate because you translate right now your screen. Could you stop your screen sharing? Julio?
Okay. I already stopped.
Yes.
So you can, yes.
Right now I can. Could you see my slides? No?
Yeah, but you need to
Yes, we can see your slides.
Yeah,
okay.
you have to put the presentation mode. There you go. It's okay. We are saying it now.
Dear colleagues, I would like to share with you our experience in blade sparing surgery for locally advanced rectal cancer. And when we look on the incidence of locally advanced colorectal cancer, we can find that from the all colorectal cancer, it's some authors demonstrate 40% of incidence. But when we look on the urinary bladder involvement, from this 40%, only from 5 to 10% have involvement of the usually posterior wall of the bladder. If you look at the biggest data, which included all colorectal cases with urinary bladder involvement, we can find that usually it's not a huge number of the patients, and it is a very heterogeneous group of the patient, and usually patients included in the study, not more than 90 patients. But a few studies from Russia demonstrate 200 patients, a little more, and current data, it's the biggest, and it's included 330 patients. But in this study, we included patients with colorectal carcinoma during 30 years period of time, and with all stages of colorectal cancer. Of course, these patients should underwent bladder resection. We did not include in the trial patient after total pelvic exenteration, patient who underwent only symptomatic surgery, and had a rare histological type of the tumor. This is a flowchart diagram of our study, and today we will talk exclusively about rectal cancer, and we will not talk about colon cancer. We recently published results of treatment of a patient with sigmoid colon cancer, and you can find it later. So when we talk about rectal cancer, 136 patients, the average age was 62 years, and male sex was dominant because female have uterus, and it's a rare case when rectal cancer invaded into the bladder in female. And we also can find that for the last 15 years, we have dramatically increasing almost 2 times incidence of multivisceral resection, especially when rectum resected with urinary bladder. Preoperative characteristic, we should mention that almost 40% of our patients had complications before surgery. Usually it was partial bowel obstruction, and sometimes it was some inflammatory, such peritumoral abscess or infiltration. And you may see that almost 4% underwent preoperative antibiotics therapy, and neoadjuvant therapy underwent almost half of the patients. I should mention that all of this procedure performed by open approach, and average time of the procedure was little more than 2 hours, and this person had intraoperative complications. It was bleeding, it was damage of the nearly structures and organs, and also perforation of the abscess. In 95% patients went for anterior resection, and we perform primary repair surgery without any prevention and directing stoma. The detail of anastomotic technique, it was in all cases, it was Hands-Yun anastomosis, and in our paper you can find detailed description of the technique of this anastomosis. So full thickness resection of the bladder wall underwent almost 62% of our patients, and 38% underwent partial thickness resection of the bladder wall. Additional resected organs except bladder and rectum was found in 21% when resected. Only one or more, and 2 or more organs about 4%. Morbidity and mortality is one of the main problem of this surgery, but in this trial we found that grade 3 complication by clavindinda was about 12%, and postoperative mortality was 3%. Well, and moderate differentiated tumors was presented, and they were dominant in this trial, as well as second stage of the disease, but 10% of our patients had post stage of the disease. Resection margin was achieved successfully in 87% of the patient, and true invasion, as Professor Tsarkov told, post about 55%. Overall survival, here we demonstrate 5, 10, and even 20 years overall survival. It should be mentioned that 32% of this patient were censored in the first 5 years, and median follow-up was about 38 months. So 5 years overall survival was 53 almost percent, and disease-free survival 49%. In the UNIVARD analysis, here we demonstrate only significant factors. We found that, first of all, p-value on the right side on the screen, it's related to 5 years overall survival, but we also demonstrate 10, 15, and 20 years overall survival. We sacrificed confidence interval, but we demonstrate the percent of survival in each period of time. So when we perform anterior resection, when we perform anastomosis, survival was higher, but in my mind, it was related, first of all, with such factors as age, or maybe intraoperative complication, or difficulty in surgery. That's why it can be the group of the people who underwent anterior resection was much more simple, I think so. So about radicality of the surgery, in palliative surgery, we included patient with R-positive resection margin and also with distant metastasis when we did not remove distant metastasis. It's patient with first stage of the disease. Of course, radical surgery increase overall survival. And when we look on the clavindinda classification, grade 3, 4 complication dramatically decrease overall survival, and as well as resection margin and post stage of the disease. And when additional organs was noted. In multivariate analysis, increase in age increase risk of the death. Also, radical operation decrease the risk of the death almost 5 times, and clavindinda complications grade 3, 4 increase risk of the death 2 times, as well as additional resected organs. If it was noted, it's also increased risk of the death. The fact of such true invasion, childhood vulnerability index, sex, adjuvant, neoadjuvant therapy was also investigated, but it was not statistically significant, so we did not demonstrate it in this slide. In conclusion, minimization of the risk factors can improve the overall survival in patients with rectal cancer and urinary bladder invasion. And in all cases, we should try to avoid factors which depends on us as postoperative complications. So that's why we should follow these rules to avoid any decreasing of overall survival. Thank you for your attention.
Thank you so much for your presentation, Dr. Vladimir. We are going to move to the last section. This is going to be moderated by Dr. Miguel Angel and Professor Escalante. Dr. Miguel Angel, if you want to start with the discussion in this section. Para nuestros conferencistas, si quieren realizar una pregunta, pueden realizarla en el chat y serán leídas para ser contestadas por los profesores. Adelante, doctor Miguel Ángel.
Well, first of all, congratulations and thanks again for all your doctors to being here early in the morning in Russia, probably in Spain, in vacations. But well, there's impressive all your work, your surgeries, and probably we need to know what was because the talking about the lymph node dissection, lateral dissection. It's something interest for me, and I don't know if you want to support a little bit Dr. Ricardo with me. I only took that course, and I'm looking for like the specific patient to remove. I really want to find the patient, but with your work, it's probably more difficult to find the patient. And probably for the audience, how for you, Dr. Ina, or for all the panelists, the faculties, the colorectal surgeons, who is the best case to probably to start, because we know that it's something difficult. We need to be we have like a line of curve to start with that in some point, but probably the question is, which is the center or where we when we can start with the best patient to start with these dissections, because it's not like that. I have a patient with a lymph node that with all the indications that you presented to us, but it's some difficult, and the where we can have the training, or where we can find you, or it's when we can start probably is the best question too. Because all our cases are difficult, but they have like a rectal cancer, TME, or all that, but the lymph node dissection is this topic that is really difficult to us.
Yes, I can understand, and I was in the same situation, but I have a very good teacher, Professor Tsarkov. He demonstrated this technique to our young surgeons, and we assisted him many times. And first we started, of course, with open technique. So there are two options. Either you can start, this is more safe, with the open, and then move to laparoscopic. This is the first option. The second option, if you can't travel abroad, for example, in our clinic or other clinics in Japan or in South Korea or in China that perform this kind of technique, you can ask your urologists or gynecologists. It's better urologists, because they do some kind of this lateral pelvic lymph node dissection. They don't do it completely, but at least you can see how they do it, and you can ask them to control how you start. Our colorectal lateral pelvic lymph node dissection is deeper that they do in urology or gynecology, but at least you can feel this area, you can see the upper part of this, and then you can gradually move deeper, because you need some confidence to work on the vessels, to see the obturator nerve, to move the vessels, especially this can be some like strange and some horrible in laparoscopic surgery, because you move the veins and the arteries back and forth. But if you don't do anything, if you don't start little by little and going deeper and deeper, you can't do anything. And probably the good idea to start with more or less slim patients, not very obese, because it's difficult. And if you see big metastases in lateral pelvic lymph node area, it can be also very difficult because they can be attached to arteries or to veins, and this can cause bleeding when you try to remove them from the wall of the vessel. So it's better, not very large, but maybe enlarged lateral pelvic lymph nodes. It's better if the patient is not radiated, because radiated patients have specific condition of the mesorectal fat and the lateral pelvic lymph node fat. But nowadays, mostly of our patients with low rectal cancer radiated, so we can't choose really, yes. So either surgeons can come to our clinic and study this technique step by step. This is one choice. Another choice is to ask urologist, but you should choose the urologist very carefully because they are not the same. They don't do full lateral pelvic lymph node dissection, so you should understand this is only the first step. You can't study the whole technique with urology or gynecology specialist.
Okay, thank you very much. And the second question probably is you probably heard about the boil technique for the bleeding that Dr. Tiyoshi probably described in a lot of meetings, that when he have a problem in the lateral dissection of node dissection, hence with this like a profuse bleeding, and they control by the boil technique. No, this is in a laparoscopic technique. That when he had a big problem with bleeding, they put a gas inside and instill the saline liquid and start with the cautery. Start like boil there. We know that have probably more complications with this technique, but the question directly is, how could you what do you think about this technique, and if you perform this, or how could you fix that kind of problem when you have like a real profuse bleeding? How could you control that? I know probably is like go directly what you are saying, where is bleeding, but sometimes we know that only see like this fluid of a lot of bleed and say we can stop. But if we can share your experience about how to manage this kind of complications in these close and these tiny spaces.
Yes, I agree that there are different techniques can be used, but Tsuyoshi Kanishi is a very experienced surgeon. He's a very high-level expert. He has done a lot of these procedures. And what is particular, he knows the anatomy really very well. And the key to first to not to predict complications and not to allow complications to occur, and to treat complications is the anatomy. If you don't know anatomy, you can damage some very big vessel and no boiling can help. For example, external iliac artery or internal iliac artery, or what is worse, internal iliac vein or external iliac vein, no boiling can help. So if you face this complication laparoscopically, it's necessary to move to open procedure. No boiling, just open procedure and try to control the bleeding because it's life-saving. And that is why probably it's better to start with open technique, because open, you can see the whole operating field, you can see all the vessels and you can control them immediately if you have some problems. So these techniques like boiling and others are only for experts that know where is the damage, if this boiling is sufficient to control this damage. So that is my comment. Probably Professor Tsarkov can add something to this.
I completely agree with you, Inna, and I can say that Tsuyoshi is a high-level expert known in all of the world. I have two comments. First, your question, and the second question. For example, if you look at the experience of Rodrigo Perez, also well-known now expert in lateral pelvic lymph node dissection, for the beginning, he moved to Tsuyoshi Kanishi. He was working at the Tokyo Cancer Center and spent there, as I know, 1 or 2 months looking at the his type of technique, and then step by step doing it this procedure in his clinic. You really need a mentor in this area. You can choose right now. Texas, as I understand, not so far away from Mexico, and you have possibility to look at this procedure in Dallas and see the brilliant technique of Tsuyoshi style of operation. And as I know, George Chang do the same in America, in North America. Even if you would like, you can go to the China, where also a great number of lateral pelvic lymph node dissection, and South Korea, for example, Professor Choi. And if you would like, move to Moscow to see our procedures, because it is a routine practice in our department to do this surgery. Commenting the bleeding control is the main problem for the beginners and also for expert during this procedure. In expert cases, we have uncontrolled, so-called uncontrolled on the bad controlled bleeding when we have huge metastasis in this area and we need resection of some internal iliac vessels. It's a very common situation. Or if it is a recurrent case of in lateral pelvic area, it's very difficult to remove, and sometimes the problem is that the nodule penetrate some big branch of internal iliac vessels. And why Tsuyoshi use this boiling technique? Because there are some branches going from, especially internal iliacs, going to the perineal area, to the gluteal area, so-called gluteus veins. And they immediately go into deep to the channels when we goes, and you cannot stop this bleeding completely using usual technique. That's why Tsuyoshi tried to use edema, which was created using boiling technique. I do the same because there is no choice. In this case, but you, as told Inna, you should do it. You should know exactly what branch of the vessels you try to stop. And this particular technique is very, very good for stopping of bleeding from the presacral area also. If you put the swab, put some water and give energy, big energy to the sacrum bone, you can stop every presacral bleeding, except the cases when some abnormality of internal iliac vein you see. For example, from time to time, we can see such abnormality like left internal iliac vein going from the common or internal right iliac vein. And it is a big vessel. And if you damage this kind of vessel, boil technique doesn't help you. You should also suture these vessels. This is just tip and tricks, but don't start with big metastasis cases. Don't start with fat patients, and do it step by step. I'm going long way, and a lot of bleeding I met in my practice during learning curve in my past. I start more than 25 years ago. It was really open era, and it was also complicated. I invited a Japanese surgeon, visited Japan for the training of this procedure, and stop bleeding in every case. Thank you.
Thank you very much.
Thank you so much. Prof. Escalante, there is any question that you want to do?
Yes, first of all, I would like to thank to the Mexican Society of Colon and Rectal Surgeons for this kind invitation. Tonight, we have had the opportunity to share with friends like Dr. Salkov and Dr. Ina. I have had the opportunity to share some conference and congress with Dr. Sarkov around the world during the last 12 years. Dr. Sarkov accustomed us to present this kind of presentation with good quality of slides when he showed us this extensive surgery that he is accustomed to do. For example, bone resection means a big surgery, a huge surgery. I have only two questions to Dr. Sarkov. The first time, usually, how long times do you take in this kind of surgery? And second, when you mention major complication, what do you mean with major complication in this kind of surgery?
I start with the last question because I understand it very well. The major complication is unhealing wound, because this big volume of wound is really difficult to pack any tissues from the gluteus area, from abdominis rectus area. It is really a problem. And the major complication, if we have infection in this wound, it's heal months. And the first time, it is really difficult to cure these patients. These patients, we do not have lethal exitus in this after these procedures, but postoperative period are very complicated. And the first question was, I'm sorry.
The first question, how long time takes for you this kind of surgery? How long?
How long? Really, it takes more than 4-5 hours because you saw that it is not only a problem of sacrum resection. It is a problem of big mass of the pelvis, and we should control, first of all, internal iliac vessels, because it is not possible to remove this, especially high level of sacrum involvement. It is not possible to remove without controlling of all iliac vessels, especially internal iliac vein. If we divide it and go out from the tumor, from the abdomen, sacrum resection themselves takes, you saw, it is less than 1 minute, but we should prepare everything before, and it takes time. This procedure usually take us not less than 4-5 hours.
Okay, and total mesorectal excision is the gold standard for medium and low rectal cancer. Nobody discussed the advantage of no dissection of this area. Tonight, Dr. Tulina showed us the alternative of prediction with lateral pelvic lymph node dissection. Very clear. I have only one question for her. Are there any relationship between the MRI, the preoperative MRI, the intraoperative dissection, and the postoperative biopsies? Is it possible to establish this kind of relationship, Ina?
We can't now rely solely on MRI. In some patients, we can see enlarged lymph nodes, but it's more difficult to say if there are some signs of metastatic lymph nodes, because MRI classification of any lymph nodes, it's not ideal. And it also depends on the MRI specialists that looks at the MRI images, also the quality of MRI images. And of course, the surgeon himself should be able to read the MRI and to see this suspicious area and to consult with his radiologist. So in our practice, all the patients with colorectal cancer are discussed at the multidisciplinary team. And the leading person at this multidisciplinary team is high-quality MRI specialists. And even they can't always predict metastatic pelvic lymph nodes, mesorectal or lateral pelvic lymph node, even mesorectal lymph nodes, they can't effectively predict. Sometimes they say this is metastatic lymph nodes. We see on the pathology that this is absolutely normal lymph node. Sometimes they say there are no suspicious lymph nodes, and the pathology we see positive lymph nodes. So that is why we developed this more complicated tool that doesn't rely only on MRI, but we use other features of the tumor. So locally advanced tumor, very low-lying tumor, they have a higher possibility of lateral pelvic lymph node metastasis. So MRI tumor characteristics can give us better predictability of lateral pelvic lymph node metastasis.
Thank you.
I also have a comment for this, because you know, When we start to do lateral pelvic, myself, when I start, I talking from myself about myself experience. It was a period there was no MRI at all. But there were patients who need lateral pelvic lymph node dissection, especially when we look at the height of the tumor, because if tumor involved, big tumor, or T3, T4 tumor, penetrate dentate line, the incidence of lateral pelvic lymph nodes, even in this particular case, without any features, it means that 3 or 4 patients from 10 will have lateral pelvic lymph nodes, even if they receive chemo radiation therapy. You should understand this, but you should also remember that it is only tumor who need APR. It is in a huge hospital in all of the world right now. It is only from 15 to 20% of our patients. And if we reduced this number, this percentage, 1/3, it means that from 7 to 10% of our patients only need lateral pelvic lymph node dissection. Height of the tumor is very important, and the other clinical features of for this procedure is differentiation of the tumor, but differentiation is also dependent tool features, because we take only part for tumor for biopsy. This part may be well differentiated tumor, but the other part of the tumor can be, for example, mucin tumor. That's why we need to combine our knowledge about particular patients to create some score and orient on this in our procedures. Thank you.
Thank you so much, Professor. I want to do a last question for Dr. Vladimir. He's talking about the bladder sparring for preservation. I know that in traditional total mesorectal decision, sometimes we have to do a partial resection of the non-biliary fascia that can lead to an injury of the pelvic autonomic nerves. In your practice, you are preserving the non-biliary fascia or are resecting this fascia for rectal cancer?
Thank you for your question, Julio. So in case when we have anterior location of the tumor and when we have a suspicious circular resection margin, of course, we should go beyond the non-bilious fascia, but if we can preserve it, of course, we should preserve it because sexual function is a crucial question, and we should remember about patient quality of life. So that's why I think if you have possibility to preserve the non-bilious fascia, it's important and you should do it.
I think the question connected with resection of the bladder, but if the non-biliary fascia is involved, it means that these patients usually needs evisceration. Vladimir talk was about the resection. It's more high involvement of the bladder, as I understand the question, right?
Of course, if it's lower rectal tumor, of course, you will resect it prostate, not bladder. But the main the major patient of this trial was high rectal tumors. So that's why few patients had low rectal tumors because our diagnosis based on the distal resection margin. But usually patient who need bladder resection, it's high rectal tumors.
Okay, thank you so much. If there is no other questions, there is also one question from the audience. You are using a ultrasound for the assessment in the rectal cancer. I think probably just in early stages. I think, I don't know, in your experience, if you are using ultrasound.
I really
Lateral lymph node dissection or what? Or in general we use or not?
No, for staging rectal cancer, I think probably just for early stages. But there is a question from the audience that are asking about the use of
unfortunately,
ultrasound.
ultrasound investigation can give us only the information of involvement of the rectum wall. There is no possibility to investigate any others. Maybe perirectal lymph nodes is also possible to see in this case. But the gold standard of diagnosis of how to say extensive all extents of rectal cancer is MRI diagnostic right now in our institute. We really use transrectal ultrasound, very rare, very rare.
Okay, thank you so much. If there is no other question, we have to thank you. Thank you to the Russian Society of Colorectal Surgery. Thank you to the faculty from the Russia, and I really appreciate the time because I know that it's very early in Russia and it's very late here in Mexico. But we appreciate this link between our societies, and we have to just say congratulations for your lectures and hope to see you here for our Congress next November. Thank you, Professor. Thank you, Dr. Ina. Thank
Okay.
you, Dr. Vladimir. Thank you also, Dr. Miguel and Professor Escalante. Thank
Thank
you
you
so
very
much.
much for the possibility to meet you in this late time in Mexico, in Latin America. Thank you, Ricardo, for your kind participation in our meeting. And we also hope to see your participants, you personally, to our Russian School of Colorectal Surgery. Thank you very much again, and see you.
Thank you, Professor. See you.
Thank you very much.
Thank you so much. Bye.
Have a good
Bye-bye.
day. Thank you.
Thank you for
Bye-bye.
everything. Good day for the Russian colleagues and good night for all of us.
Ciao. Thank you.
Ciao, ciao.
Bye-bye.
Bye bye. Excellent.
Bye.